Hello, everyone. My name is Dr. Cynthia Keator, and I am the Medical Director of the Jane and John Justin Neurosciences Center here at Cook Children's Hospital in Fort Worth, Texas. My discussion for y'all today is discussing what is the Epilepsy Monitoring Unit, what is it all about, what do we do here, what is this section of the hospital that is busy, moving all the time, 24/7. So we'll get started. The objectives are basically wanted to start with understanding epilepsy, the diagnosis of epilepsy, what is intractable epilepsy, and what are the treatment options we look at. So I think to understand the EMU, or the Epilepsy Monitoring Unit, we have to first understand what is it that we do every single day and what is the purpose of it. And then that will lead us into what the EMU looks like, the purpose and the role, what the team is all about, who is on that team, doctors, nurses, ancillary staff, child life, the parents, the patients, and then ultimately what to expect when you are there. So epilepsy, diagnosing, and intractable epilepsy. What are these key components that we discuss in our epilepsy world and what we look at in the Epilepsy Monitoring Unit, and what the purpose and the uses of it are? I love this slide. I've used it for many, many years. My epilepsy fellowship director, where I trained in Colorado, used to use it in her discussions. So I took that from her with her permission. Obviously, it's from somebody else, but I love this slide. And so basically, you see a mom that's a stick figure who looks very, very frazzled, with a physician who is standing next to her, also very stern, very informative, who's a stick figure. And she says, "Thank goodness you're here, doctor. I came in this morning and found Billy all just scribbled up like this." And sometimes this is how epilepsy or seizures feel to parents. And it's very overwhelming when you meet them either in the hospital, in the emergency room, in the clinic, or even just out and about when you run into people and they say, "Oh my gosh, like, is this a seizure? Is it not a seizure? Somebody told me it could be a seizure." And it can be very overwhelming. And how do you go from, is it a seizure or not? And now, what path do I go down? And what are the steps to understand this? And so you see little Billy all scribbled up. And that's sometimes how we feel, because we're just like, oh my gosh, we're scribbled up. And someone's going to look at my child's brain and there's a bunch of squiggly lines. And so, no pun intended, but that's really what we're looking at, is these lines that to us make perfect sense. It allows us to read a story that we hope is a good story that starts from start to finish. But sometimes the stories don't end the way we want them to. And that is what the EMU is all about, to understand these stories and make these stick figures look normal and straight again. And how do we do that? So let's talk about epilepsy and what epilepsy diagnosis is, and what are the classical definitions that we look at when we study epilepsy. So today, epilepsy is defined as a disease that involves recurrent or unprovoked seizures. So basically, this means that it's not due to a head injury, so an acute traumatic injury, not due to a seizure, a fever, not due to something like a stroke. So basically, something that just happens out of the blue. So an unprovoked seizure, and they have to be recurrent. And recurrency is defined by 2 unprovoked seizures that are more than 24 hours apart. So sometimes there are conditions where children will present with multiple seizures back to back within a 24-hour period, or a cluster of seizures. And if it's the first time they present with that, we still define that as the first seizure. So even though there might have been 5 in a 24-hour period, we define that as just one seizure. Now, if they had a single seizure or a cluster of seizures, and then say 3 weeks later or 3 months later they had the same thing, then those would be your 2 separate events. And so that's how we define that as epilepsy. We know that 1 in 10 people in their lifetime will have a first-time seizure. So that's a very, very large number of people when you think about 7 billion people that live on this earth. So 1 in 10 will have a first-time seizure, of which the majority of them will never have another seizure. So some people in the literature will quote up to 50%, some will quote up to 70%. So I usually say 2/3 of patients who have a first-time seizure will never have a second one. And so that's why when you go to the emergency room and your child has a first-time seizure, they say, it's okay, it's likely not going to happen again, because statistically speaking, it probably will not happen again. Most of these patients still undergo a workup just to make sure that there isn't any increased risk, or are they in that 33% that are in that increased risk that will have another seizure. But for the majority of time, your child usually will not have a second seizure. However, if they do have a second seizure, that ratio flips. So now your 2/3 more likely to develop more seizures. And so that's why we call it epilepsy. As a whole, when you look at all patients who are amongst us, 1 in 26 will develop epilepsy. So that's about 3.5 per every 100 people will develop epilepsy when you just kind of look at a group of people. When you take that to larger numbers, that means 50 million people in the world have epilepsy, of which that's over 3 million people that live in the United States. So that's a pretty large number. I know we live in a large country, but it's more frequent than we give it credit for. And it's amongst us all the time, sometimes in our immediate families and sometimes in our friends and in our neighborhood. So I think we need to be educated, more cognizant of how real this is and how we treat this and what to do with it and how to be educated. We get about 150,000 new cases a year, of which 1/3 or 30% of those will be pediatric patients. And we look at children specifically. So these numbers I'm telling you are all patients. So from ages 0 until however old a patient is. So that's pediatrics and adults. But when you look at just specifically children, about 5 in every 1,000 children will have epilepsy. So that 1 in 26 is all populations of pediatrics and adults. But when you just specifically look at children, 5 in every 1,000 group of children will have epilepsy. So still pretty small, but to me feels very common. And I know to you it feels very common because it affects your livelihoods every single day. So this is a busy slide, but I think it's important. This is how we look at epilepsy today. And so, and I think there's even a newer revised term for the International League Against Epilepsy for how we categorize seizures and epilepsies and their syndromes. And so every year, about every decade, we get together, we're super nerdy, and we say, okay, we could do better. And that we could always do better. And so how do we think about seizures and the syndromes that they're categorized in? Because it allows us to put it into a picture about, okay, this is what this patient has, we need to do X, Y, and Z. Or this is what this patient doesn't have, so we do not need to do those tests. And I think the goal, once you make the diagnosis, is really understanding 2 things. 1, why is this happening? And 2, how do we control it? And sometimes those are 2 different paths, but they have the same goal, which is to find answers and make it better. And so when we look at the terminology, you can see just looking at the left-hand side, there's something called generalized seizures. These arise rapidly and are bilaterally involved. So in other words, both sides of the brain are involved. And these are the variety of different types of seizures you can see. You can see tonic-clonic, absence, clonic, tonic, and atonic. Then they have their own kind of special features that can be broken down. We have focal seizures, and that basically means it is in one part of the brain, but it can spread to both sides. So at the very bottom, you can see that it can, even though it starts in one place, it can look generalized, although it's not. It just started in one place and electricity can spread. And then, of course, there's always the unknown classification. So something that doesn't really fit into either category. And so those are still things that we're trying to understand. And so are they generalized? Are they focal? Are they both? We're not really sure. And that's where the EMU comes into play in the things that we do. And so just to let you know, for those who are familiar with infantile or epileptic spasms, that's the category that unknown comes into, because sometimes epileptic spasms can be focal and sometimes they can be generalized. When we talk about how we treat epilepsy, we always look at how do we get to seizure freedom. And this has been repeated in the literature multiple times, and we still come to the same conclusion every time. So when you get a diagnosis of epilepsy and you start a seizure medication, assuming that you are correct in your diagnosis, assuming you are correct in the type of epilepsy syndrome or seizure categorization they have, you pick a medication. So most of y'all are familiar that certain medications are better for certain epilepsy syndromes or types of seizures. So if you pick the medication, you have a 50% likelihood that you will become seizure-free on that first medication. If you do not become seizure-free on that medication, then you pick a second one, or you add a second one. Oftentimes we add so that we're not making too many changes at once. And when you add that second medication, that 50% ratio has now dropped to 15. So now there's a 15% likelihood that that patient will become seizure-free. For every single medication after that, so your 3rd, your 4th, your 5th, or your 10th, every time you add a medication after you've failed 2 medications, you have a less than 5% chance that that 3rd medication or anything after that will make that patient seizure-free. So taken as a whole, there is a 30% chance that your child or your patient will become intractable, which means will not respond to medications. That seems small, but it's actually a very large number, and it's a big portion of the patients that we care for with epilepsy. Is that a third of patients will become intractable. And I think that's important to remember as we think about other treatment options. And I'm sure you'll hear other discussions from my colleagues here at Cook Children's about these other treatment options for patients with intractable epilepsy. So stay tuned for all that great information. So what are, in a nutshell, I'm going to tell you just real briefly our treatment options, and then we'll go into the discussion about the EMU. So medications is what that previous slide was about. The medications was basically there are FDA-approved medications, some that are not, that are in drug trials, and that is definitely usually where we start. But there are other things that we can do for our patients who have epilepsy. Some of you are familiar with some of our surgical management, and so some patients are who we call surgical candidates. Some patients undergo diet modification with ketogenic diet or modified Atkins diet or the low glycemic index diet. We do neurostimulation, so that includes your vagal nerve stimulator, your NeuroPace or your responsive neurostimulator, and deep brain stimulation. There's something called biofeedback. So there are some very, very, very limited case reports and what we call neurofeedback or biofeedback, where you can kind of train yourself and how you are able to kind of calm yourself down for some of your seizures. I talk about that cautiously because it is a very small series of case studies, literally 5 to 10 patients, and it's all adult literature for the most part. So something that I'm not super familiar with, but is reported in the literature. And then other things that families have tried, different diet therapies or treatments. But taken as a whole, when you look at treatment options, I think it's important to know that while we often start with medications, there are other things that we consider. And some of these things are things that we consider when that patient becomes intractable. Please note that some of these other treatment options like diet therapy, neurostimulation, even surgery in some regards, are all usually adjunctive with each other. In other words, the reason the circles overlap each other is because sometimes they're used in combination. Sometimes you have to use more than one thing to help control seizures or at least minimize seizures. And so when you do one of these other options outside of medications, it does not mean that you will necessarily come off medications. That's always the goal. The goal is always to be seizure-free and off medications, but just be cautious that sometimes we do have to use a combination of the things that are available today. So what is the impact of epilepsy, especially intractable epilepsy? So why do we care about it so much? Why do we talk about why we have the EMU and what we do here? Because there are several things that it affects in our population, especially in our pediatric population. Cognition is the big one. So especially if you develop seizures or epilepsy early in the first couple of years of life of development, that can significantly impact the rest of your life because that is when your brain is most rapidly growing and developing. So if seizures are not well controlled, especially at an early age, we know that that will significantly and adversely impact cognition long term. So we know patients who are well controlled as soon as they are diagnosed, and the younger and the sooner you diagnose them, and the younger and the sooner you can control them, the better their outcome can be. So we can see that in long-term scores over different populations as well. So obviously, best case scenario, seizures are controlled, you get to come off medications, great. We know those patients do the best versus patients who still have seizures and have to stay on medications. We know that long term, the more you have seizures, the seizure burden can adversely affect your cognitive impact and your development long term. And with that, the quality of life of these patients becomes significantly impacted as well. Epilepsy has a very unpredictable course. You know, I wish I had a crystal ball. I wish I could tell families, no, you're not going to have another seizure when we come off this medication, but we really don't know. And there's so much we have left to understand about this condition. But because it's unpredictable, it becomes very stressful for the patient, their family, and their friends. And there's a lot of associated stigma with it too, right? You know, there's a higher risk of depression and suicide, and there's a higher risk of higher divorce rate and lower socioeconomic status. Am I going to go to college? Am I going to be able to finish this? Am I going to be able to drive a car? I mean, these are real things that are very, very impactful in our lives that we take for granted every single day. And, you know, when you look at these families and these patients, you know, you really have to understand that so much is going into why we work so hard for our families. We know that patients with epilepsy, especially intractable epilepsy, have a higher chance of mortality than the general population, as high as 2 to 3-fold increase. And when you look at just intractable epilepsy as a whole, when you look at the cost of epilepsy care in the United States, 80% of that cost is because of that 30% of patients who are intractable. So it just makes me realize we could continue to do so much better. And we are always working hard to understand what are the other options, which kind of goes back to that previous slide about why we offer other treatment options in adjunctive to medications, because it's a real thing and it's a real concern that we want to address and make sure that we are able to do the best we can. So let's go to the basics. So enough about the history and the understanding of what we're going to talk about. So let's talk about the EMU. So let's go to the basics here. So what is the EMU? So the Epilepsy Monitoring Unit is an evaluation that plays a crucial role in the patient's diagnosis and management with seizures and epilepsy. The EMU ideally is a specialized inpatient unit designed to evaluate, diagnose, treat seizures using state-of-the-art continuous video electroencephalograph monitoring technology. So here at Cook Children's, we have a 10-bed wired EMU. So basically there is a camera that is wired into the room, and so their patient is not hooked up to the machine, the little computer. So basically even though they have the EEG leads on and there's a cord that plugs into the wall, they have pretty good free range to walk around the room and do the things that they need to do without feeling that they're tied up to a big computer that they can't really go very far. And so that's the idea, is that this is state-of-the-art technology where we can monitor these patients and diagnose them. Most patients are monitored for several days. Some patients are only monitored for several hours, and we get what we need and they're able to be disconnected. But we have the capability of monitoring them for several days, so up to the full week if we need that. The purpose of the hospitalizations is to record the patient's events and help the patients get the best treatment to improve their quality of life. It also allows us to characterize other events that may look like seizures. So remember, when we meet families and they say, oh my gosh, I think it's a seizure, someone told me this could be a seizure, and you hear the story and say, yes, there are things that could be concerning for seizures, but hey, maybe it's not. Maybe maybe your child is just having tics or other kinds of behavior spells, which is very common, that children can do lots of things that do look like seizures but are not seizures, and they're very benign. And so I think that's the other nice thing about the EMU, is it allows us a chance to say, hey, it's a very well-controlled environment. Let's just see what we get. And we say, look, nothing to worry about. It's not seizure. And then we all go about our day. So EMU can be used for a variety of other things as well. So the purpose, what type of seizure are they having? What we look at when we use the EMU, besides kind of characterizing what is and what isn't seizure, we want to know what type of seizure they're having. Remember that slide where I said, is it focal? Is it generalized? I'm not really sure. So it allows us to answer that question when we're trying to pick medications. Are the medications working? So sometimes the families say, I'm not sure, like especially with absence seizures. So a lot of patients with absence seizures, hey, they're kids, half the time they ignore us anyway, right? I know my daughter does. So when you want to see, is it really an absence seizure, or are they just ignoring me? And that's okay. That's what we also have the EMU for. So it's not always, hey, we have to make a diagnosis, or hey, we have to look for a surgical evaluation. Sometimes it's very basic, like I'm having a hard time knowing, and before I let them drive, can we make sure? Absolutely. So that's also another thing we can use for the monitoring unit is, hey, do we have what is our seizure count? What's our seizure burden? So are the medications working? And so that leads into the next thing. How many are they having? So sometimes we need to understand if we're even with our medication changes or whatever treatments we're doing, how often are they happening now that we've made that change? So we can use the monitoring for that as well. And then kind of going to, is it a focal or a generalized seizure? Where are they coming from? Helping us understand that once we understand where the seizures are coming from, what other steps can we do to help that patient and go down that road for other monitoring or other evaluations that may be indicated. The monitoring is a place that allows our patients to undergo their evaluation. It's got team members which we'll go through. It allows us to understand how to respond to the seizures, how to document the seizures, allows us and the technicians and the nurses to describe what we're seeing, characterize it. Do they turn to the left? Do they turn to the right? Oftentimes it's very stressful. The seizures can be very short, under a minute, and you're trying to remember, is that their left or my left? And so it allows us to kind of answer those questions as well. What does it look like? Are their eyes, deviating up? Are they to the left or to the right? Are they picking up things? Are they able to communicate? Are they not able to communicate? So it allows us to understand those characterizations of the seizures. Gives us plenty of time to do lots and lots of education. When we meet the families in the clinic, it's usually a brief visit on, for about an hour, and you can't think of all the questions you want, number one, and you don't have time to think about that next step about, oh, I forgot this, which that's fine. You can always call us, but the EMU at least allows us a time where you have time to get educated on whatever those questions are. Get a library consult, meet with other families, look at our videos that are on the website too to kind of understand seizure safety and everything we have to offer. And like I said, once I diagnose a seizure and see if we have a focal seizure, a generalized seizure, are there other steps that we would lead to for their care and the management of that particular patient? So like I said, there are many roles for the EMU. It allows us to understand whether it's an epileptic seizure or a non-epileptic seizure. Like I said, non-epileptic seizures can be tics, they can be stereotypies, they can just be lack of attention, they can be a sleep disorder. So many different things that can look like seizure that are not. So the EMU has a great role for doing that and allowing us for continuous monitoring. It allows us to make the right diagnosis in a seizure disorder, allows us to characterize that particular type of seizure, and is a wonderful place too when we're looking at patients. It's a safe place because we've got the capability of having our ICU team and all our other physicians and care partners when we are taking these patients off of their medication. So sometimes we do the opposite. We're not trying to make the diagnosis. We know the diagnosis. We need to take them off of their medications to understand more information. So we put them in this monitored environment in a hospital where there's nurses and staff and ICU and equipment ready if there is an emergency, which is rare, but it's a safe place that allows us to monitor these patients off of their seizure medications, especially when we evaluate for epilepsy surgery. So what type of seizures are they having? Like what I mentioned, kind of in a nutshell, there's generalized seizures that mean that they come from kind of a diffuse network all over the brain. Focal seizures, meaning they start in one part of the brain, and then of course non-epileptic seizures, whether that's tics or recall or psychogenic non-epileptic events, so things that look like seizures, but they're normal on EEG findings. And so it allows us, when we're in the EMU, to kind of decide, hey, what are my next treatment options for this family or this patient? So if it's generalized seizure, we know we have plenty of things to choose from: medications, diet, surgeries, neuromodulation. Focal, same thing. And then, of course, if they're not seizures, then do they need therapy, or is it just benign and there's nothing to do about it? And it's just something they're going to outgrow because it's just a pediatric behavior that a lot of children have. There's always risks and benefits with everything we do in medicine. The EMU is no exception to that. But overall, we find it very, very helpful and very safe, or we wouldn't do it, obviously. And we wouldn't have such a big unit and a big team. But when you look in general about the adverse events of an EMU admission, it's pretty small. So there was a study in 2011 that looked at a little over 500 patients, of which only 44, so small, it was 9%, who had an adverse event. So basically that was, they had an episode of psychosis, because obviously it can be very traumatic being, kind of confined in a room for some patients. Some patients were reported panic attacks. The big ones that we worry about, obviously, is we're taking patients off of their seizure medications. So that does put them at risk for prolonged seizures or status epilepticus. Obviously, we try to mitigate that by having a peripheral IV in place, so we have immediate IV access to use medications to abort the seizures. Of course, we have a code team or a med alert, or we have our ICU team come up immediately that is just the floor below us, so they can easily come up and assess the patient for emergent situations. And then falls and fractures. So obviously that's always a risk for anybody who has a patient with epilepsy, is they can always fall and have an injury or fracture. And so there are certain things that we do in our EMU to keep them safe in the bed. So we have padding so that they're in a safe area on the sides of the bed in case they go into a seizure to protect them from falls and fractures. There was a study in 2009 that showed benefits of the video EEG monitoring. And you can see this is why this place is so important, because in up to 41% of patients, it actually changed the diagnosis. So there's nothing more frustrating than having the wrong diagnosis, right? It's like, oh my gosh, for years I was told I had this, and now you're telling me I have that. And that makes it very hard to be trusting and understanding of what we're going through. And so sometimes when we meet these families, we say, you know what, I'm really worried, but I don't have enough information to really give you that diagnosis. And while that sounds like we're coming from a place where we don't know what we're doing, that's not true. Sometimes it just feels like, hey, I really want to make sure before I give this diagnosis. And sometimes it's very black and white and very obvious. You know, you can hyperventilate them in the clinic, they have an absence seizure, boom, you're done. Or they had a routine EEG prior to the appointment and it gives you that diagnosis. But sometimes these events happen only at nighttime, or sometimes they happen every other day. And so the EEG monitoring really allows us to make those diagnoses. So one of the benefits of it is that it can change the diagnosis for the better. The other thing is, along with that, it can change your treatment plan. So what you thought might have been a focal seizure turned out it was a generalized seizure, and that's a totally potentially different treatment plan. Or vice versa. What you thought was a generalized seizure was really a focal seizure, and so it can help guide treatment. So those are pretty big numbers and the advantages of the EMU monitoring. Lots of education, like I mentioned that earlier. The advantage of the monitoring unit is it gives us a ton of education for the family. It helps them understand what they should look for during a seizure, what to do during a seizure, kind of have an action plan at home and at school, teach family how to administer medications, especially if there's rescue medications, or we're going to change therapy. You know, it's a lot of these children are young and don't want to take pills. And so how do you get them to take them? Or how do you crush a medication if they don't like the liquid formulation? How do you sneak it into something? And I've heard some really cool things my families have done with some of their child seizure medications. And hey, if it works, it works. We're always willing to hear what families have learned, because it teaches us well. It teaches us as well too. You know, there's one family who said, you just freeze it and then I cut it in half because it's a gel cap. I'm like, oh, who knew? You know, because these big, these pills can be so big, and how do you make them smaller when they don't come in a smaller size? It also gives us the time to review other medications and treatment options. So when patients come in, especially who have intractable epilepsy, and they said, hey, I've already tried X, Y, and Z, let's talk about diet therapy. Let's talk about, is my child a surgical candidate? So it gives us more one-on-one time with these families as well. And like I mentioned earlier, we have lots of educational videos on our website that our nursing staff and our nurse educators can go over with the families if they want some more information. So let's meet our team. Lots of people involved and lots of happy faces for the most part. So physicians and nurse practitioners, so they're the ones that you're going to see every single day. Their role is to not only obtain the history, but interpret and create a plan each day. So usually there is a single nurse practitioner who will be taking care of the patient daily, along with the physician for that week, who is one of the epileptologists. And so our role is to say, okay, this is what we saw on the EEG. We interpret the EEG daily. We review it with the parents and the nursing staff at the bedside, and then we come up with a plan. Are we going to continue to do this? Are we going to hold medications? Are we going to add medications? What are we going to do that day? Like I said, we're going to update and educate the team every single day. So we update like I said, the nursing staff and the families and the child about what we're seeing and what the goals are every single day. So sometimes the kids are scheduled to come in for 3 or 4 days, and sometimes we get the answers in the first 24 hours, which is great. So the sooner the better, right? No one likes to be hospitalized. And so sometimes we anticipate we may need more, but we can always shorten the stay. And vice versa is true. Sometimes we need more time. And so maybe sometimes we thought we would get it in 2 days, but we didn't. And so we just asked for extra days. So you can also do that as well. And then always you can just go to the person for any questions or concerns. So because the physicians and the nurse practitioners are available, please do not hesitate to ever say, hey, can you come back and just review that with me again? Just like in the clinic, things can sometimes go very quickly, and it can seem like it makes sense in that 20-minute period, but then all of a sudden 2 hours have passed and you're very confused at what happened, and that is okay. So that is another advantage of the team with the EMU is, hey, can you go over that with me again? Could you get me more information about that particular seizure type or that particular medication? Our technicians, they're wonderful, they're wonderful, they're wonderful. Some of our staff has been here for many years, and they are our eyes and ears of the team and the neurology team. They're the eyes and ears of the nurses, they're the eyes and ears of the doctors and the nurse practitioners, and for the families as well, because they are the ones that are kind of behind the scenes. So the cool thing about the EMU is that while you're in the room and you're getting monitored, there is this kind of magical place, I call it. Almost looks, like mission control. And you're basically can see all of the patients being monitored in the hospital at once, and you can see everything that's going on. So they can see it sometimes before the patient has a clinical change, before the family notices it. And so they are eyes and ears. So especially after hours when the kids, it's bedtime, and even though there's people in the hospital, children are sleeping. And so what's going on when they go to sleep, and they can see if the seizure is starting, if they're in the middle of the seizure, and they can notify the team so we can get to them immediately. They document and they assess what's going on. So they will mark the EEG. So when we look at things, we know exactly when, things started, when things stopped, how it evolved, how it changed. So they just help, even though we're the doctors are the ones reading it, we at least have a little bit of guidance about what happened the night before, the day before, or what happened during the seizure. So the technicians are constantly reviewing the EEG with annotations. They're literally doing it constantly. They are here 24/7. They maintain the equipment and the quality of the EEG. So they make sure that the electrodes are placed where they're supposed to be. They make sure that they are reading correctly. Sometimes, children sweat or they pick off the lead. And so that affects the monitoring because then we can't interpret it. And so they see that right away, and they're able to adjust that right away so that it doesn't interrupt any of our recording. They make camera adjustments, so kids are mobile, especially little toddlers. So if toddlers are running around the room, the camera can move with them. So you can actually see the camera move when you're in the EMU in the hospital room. So they adjust that. Like I said, they're their eyes and ears. They're constantly communicating with the staff. One of the things that we worry about is scalp breakdown. So when the EEG leads are placed, it's a metal disc, and so it can irritate the skin, especially over time. Of course, the younger the child, the more sensitive the skin, but even after several days in an older child, you might start to get some redness or irritation. So they are constantly going in, making sure the integrity looks good and the skin looks healthy. They do the testing when able. So if they see a child kind of pausing or staring, or there's a change in the EEG, whether it's seizure or not, they can beep in and say, hey, are you okay? Do you notice anything? So just to make sure that we are clinically testing when we need to be. And of course, troubleshooting. So, hey, something doesn't look right. Let's go fix this. Let's go fix that, just to make sure that we can get the best quality of the studies. Our nurses, our bread and butter of our hospital, the ones that keep this place moving and shaking, they do it all. They obtain the history. They make sure that medications are where they're supposed to be. They ensure the safety of the patient and the family. They're the first ones in the room, essentially. So when the seizure happens, whether we're seeing it on our side in the control room or the family pushes the button, the nursing staff is going in saying and testing, like, hey, are you okay? Show me 2 fingers. Where's your mom? Tell me your name. Where are you? And so it sounds kind of obnoxious, but there's a point to it because they want to see if they're able to respond or not. So it allows us to interpret the seizure as well based on what they can and cannot do, because obviously the brain, even though that's where the seizures come from, the brain controls everything we do. And so it allows us to understand, okay, the patient cannot communicate. It looks like they're trying to understand, but they can't get the words out. So does that tell us that the seizure is coming from the language function? So there's a reason behind why we do these things. Or squeeze my hand and, hey, I'm not able, you realize they can't do anything with the left hand, but the right hand's working just fine. So again, allows us to understand lateralization of the seizure based on the brain function and the way it works anatomically. They do lots of education, they do lots of documentations of the seizures, and they assist with communicating with the rest of the staff as well. Our parents are our greatest advocate. We want them to be actively involved in their child's care. We want them to understand what they're seeing. We want them to ask questions. We want them to be educated on epilepsy and the diagnosis and their medications. We want to help teach them what to do when a seizure occurs, not so much in the EMU, but out in the real world. So in the EMU, we want them to kind of see what we're doing so that they can, in turn, feel comfortable at home to explain that to their family members or to the school, like, hey, this is how we keep them comfortable, how we keep them safe. This is when you administer medications. This is how you respond to the seizure. And, we encourage families that, when they push the button, oftentimes the tech will say, Mom, what are you seeing? And they'll say, it's like, they're not making eye contact with me. And even sometimes when they're events that are not seizures, if you push the button and say, hey, I think they're doing their event, and it turns out it's not a seizure, and that's okay. We still want you to document, hey, what are you seeing? Because that helps us understand, hey, did we answer that question for you? Is this what you're seeing at home? So we want you to be as involved as you possibly can be or want to be, so that we can help answer those questions of why we've asked you to come into the hospital in the first place, to be able to make that accurate diagnosis. Patients are the center of our focus. This is what we do every day. We're pediatricians at heart. We wouldn't want it any other way, but they are our focus. And so we want them to be involved as much as they possibly want to be involved. And we understand children have different developmental abilities and are different ages, but especially for our older ones, we want them to really be an advocate for themselves. So we know parents are the biggest advocate, but we really want our children to be advocates for what they're going through. And we want them to be able to communicate with us if they'd like to share with us, because we want them to take control of their lives and realize that their life should be no different than any other child. The quality of life is the most important thing. While we are definitely trying to diagnose and control seizures, we want them to understand that their life should be no different than anybody else. So we want them to be involved in that process. They could be say, hey, why was the button pushed? Like, what did you see? What's going on? So those things that we want them to at least be educated about and be as involved as possible. So how do we respond to the seizures? Well, we want to control the seizure as quickly as possible, right? So that's whether we're in the EMU or outside the EMU. We want to ideally prevent seizures from occurring, right? So what's not working? Hey, we've had 3 seizures since our last medication change. It's been a couple weeks. Do we need to make a change? Do we need to go up on the dose? Do we need to go down on the dose? Do we need to try a different medication? Do we need to come into the EMU? So how do we prevent that seizure recurrence if we keep seeing more and more in our daily lives? We want to maintain patient safety, and how do we do that? And we're going to go through that. And then again, like I said, we're always trying to figure out, well, why is this happening? Is it because the medication's not working? Is it because we have the diagnosis wrong? Is it because we chose the wrong medicine? So things like that. So I think we need to always kind of consistently think like, what is not working, so that's why we bring them into the EMU to answer those questions. So this is why we're here, right? So we want to care for the patient and characterize a seizure, right? So we want to get the right diagnosis, and we want to make sure we can get the seizure controlled. So especially for the big convulsive seizures, so seizure safety, we want to make sure everybody's safe. So we want to assess the situation, make sure their head is protected. If you see a patient going into the seizure, can you help them safely get to the ground? If they, and protect their head, we don't want to cause injury. So if there's any objects around them that could hurt them or injure them, you want to get them out of the way as soon as possible. Like I said, you cushion their head. You want to time the seizure, check the time. Is it, how long did it last? Obviously, most seizures are going to stop in less than 5 minutes, which is why we use the 5-minute mark. So the majority of seizures will end on their own in less than 5 minutes. We know if the seizure doesn't stop in 5 minutes, there's a higher likelihood that it's not going to stop without some rescue medication. So calling for 911 or an ambulance, or administering rescue medications if they're available. If you're out in the real world, then is there a medical bracelet to identify the patient if it's not somebody you're familiar with? Trying to get them on their side. So ideally, we ask you not to touch the patient if they're in the middle of a seizure, but we do want to get them to their side either as soon as we can or when the seizure is done, just for the risk of aspiration or choking. If they have emesis or vomiting, or they have a lot of drooling, then we want to make sure they're on their side. And never, ever, ever restrain them. So a lot of times your arms will get stiff and your legs will get stiff, and then and when you go into a seizure activity or a tonic-clonic seizure, and by restraining them, you can actually do more harm than good. You can actually injure them, or they can even hurt you because you can become incredibly forceful during a seizure. So either you helping or the patient could be injured. When you walk in during the EMU, so whoever walks in first, whether that's the doctor, the nurse, or the technician, just start describing the seizure. So if you walk in, you see the seizure, you want to turn the lights on, you want to remove the covers, You want to turn to the patient to the side if you can. You know, say, hey, it's, you know, the tech is on the other side saying, hey, it's been going on 3 minutes, you know, so that allows the nursing staff, okay, I got to start getting rescue medication ready. The tech will tell you, it's like, hey, I can't see the patient, like get out of the way, you know, so making sure we can see everything that's going on. Try to be, you know, supportive. You know, when we do our training for basic life support, one of the things they say is, okay, everybody needs to be calm and everybody has to have a role. So basically it's like, okay, I'm the one that's going to, you know, be in talking to the patient, assessing things, you know, you're going to be in just making sure, you know, the lights are on or removing the covers, you know, so things like that, trying to be as calm as you can and be organized. I know it gets a little bit stressful, but just try to be as organized as you can. As the seizure is ending, you know, does that patient need some suctioning? So things that we can do because we're in the hospital setting to be able to aid that patient. You want to evaluate, make sure that they're recovering. The advantage of the monitoring, obviously, is that we can see the EEG and we can see what's going on. We can see their brain recovering, say, hey, it's done. We're getting better. We're recovering. We're seeing the normal waveforms. And then, of course, if the seizure is longer than we need it to, obviously, we're in a situation where we can treat. So we have a variety of rescue medications we can administer when they're in the hospital. Evaluation, like I mentioned this earlier, hey, you know, can you communicate? So are they able to speak? Are they not able to speak? You can say, hey, you know, what's your name? Point to the door, things like that. So can they understand? Point to the door, hey, you know, show me 2 fingers. So can they understand things, or can they actually verbally communicate? We want to look at their eyes. Are the eyes opened? Are they closed? If they're open, which side are they going to? Do they have eye fluttering? Do their pupils react to light? We're going to evaluate movements. So is it just the left side? Is it the right side? Is it both sides? Is one side extended out? Is one side not used? Are they not using one side at all? Are they having what we call hand automatism? So are they fumbling with their hands or picking at things that, you know, as if they see things that are not there? Do they just have rhythmic jerking? Lip movements, so do they have lip smacking, lip chewing, drooling, do their heads go to one side or the other? So a variety of things that are not even listed there, but definitely all these different things that we're constantly looking at to understand the type of seizure that they're having. Communication, are you okay? Remember purple elephant, that seems to be the one I use. I think that's the one my partners use too. You ask them to remember something, so when the seizure's done, you ask them to remember, do you remember what I said? Yes or no? That's really, really big with absent seizures, just to see if they're responsive during the seizure. What's your name? Where are you? Who are you? Point to your mom. Is this a pen? Is this a watch? So just really basic questions. We have to be really careful not to do things like, who's that? And, you know, your mom, like the kind of rote memory. So rote memory, we try to avoid those things. So we try to ask a little more complex, like, you know, point to the door, you know, show me 3 fingers, you know, or point to the door and then point to the wall. So things like that, that's a little more simple. It's simple, but yet complex and not rote, to really make sure we can test their mental state. Squeeze my hand, touch your nose, show me 3 fingers, things like that. Patient education, we want to press the seizure alarm during the seizure. That's when the tech notifies the nurse, if the nurse is not aware, to go in and help if necessary. And that's what we talked about, you know, the patient or the parent should be able to verbalize why they press the button and what they see. So remember, you know, oh, they weren't listening to me, or, you know, their right arm started to stiffen. And of course, whoever walks in the room, they will start to also do the same thing. They'll talk out loud, so it's recorded. Remove the sheets, avoid blocking the camera. And then again, the tech is monitoring every single minute. So if the seizure's going on too long, they'll say 2 minutes, 3 minutes. And so that, you know, so then there's multiple nurses that are getting ready to do the rescue medications if needed. Documentation, we're constantly documenting everything that's going on while the patient's being monitored. It's basically like a story. Like I said, we're going to read the story from start to finish, and hopefully the story ends very nicely. And we have that script to kind of answer those questions and those changes we made or the things that we saw. So the technician is documenting a lot of that. And then the doctor will go in too and say, you know, I saw it start from the left side and then it went to the right side, and then it went back to the left, you know, so we document so that when we go back, we remember what we saw. Obviously the squiggly lines never change, but at least our documentation helps us kind of remember the story. Or especially when we're reviewing patients several weeks after the hospitalization, if they're undergoing a surgical evaluation, this is the one that I really wanted to show you. This is the best example. And this is why it's the best example, because we have that documentation. The nurse and the tech should take 5 minutes after a seizure. So basically when everything is done, we want to take some time, several minutes after the seizure, just to make sure we reviewed everything and that we've documented accurately. We might have said, hey, they looked to the left because we were in a hurry. And then we look at the video and we say, oh, no, they really looked to the right. So we just want to make sure we adjust those things. Things are happening in a hurry, but because things are video recorded, it allows us to go back and just make sure that we got it correctly when we review the final report. And then just kind of quick, the last part is really just the basics of EEG monitoring, what we do, what to expect, and what it can ultimately be used for. So the placement, it's usually done at the bedside or in the procedure room. Thanks to COVID, most of the time we're doing in the bedside, which I think is more comfortable anyway for the patient. It's usually very, very quick. It lasts for about 30 minutes to put the 21 leads on the head. If needed, child life is available. So, things to distract the younger children, whether that's watching a cartoon or a movie or playing on an iPad, they can't really move. So it's not like they can run around and do an activity when the EEG is being hooked up. They have to be pretty still. So being able to do activities like that just to kind of entertain them. They can be taped or glued if we know they're only going to be here for a short period of time, we can tape them. So it just makes it easier just to wash your hair when it's over. If we know they're going to be here for several days, it just makes it easier to glue them. So we're not going in and having to replace them every 1 to 2 days because they start to get kind of loose and then they don't work as well. So we want to make sure that they stay on the scalp so that we can accurately monitor. So sometimes they're glued instead of taped. I mentioned earlier, the techs will be checking for breakdown of the skin. And then, of course, we try not to remove the leads until we're absolutely done. So in an emergency, if they have to go down and do something like a brain scan, then they're going to have to come off. But ultimately, we try to do all of that at the end once we're completed to remove the leads. We're monitoring for the onset and the offset, the seizure count. Do they all look the same? Are there multiple onsets? Is it a single onset? How is our treatment working? What type of seizure is it? Is it not a seizure? And just describing what you see. So just kind of in summary, this is what it's all about. We also do the surgery evaluation. So the EMU is also a place where it allows us to hold seizure medications and monitor the patients in a safe place. We have an IV in place if emergent treatment is needed. We have a very comprehensive epilepsy program here. So most of y'all are familiar with that and with our comprehensive database where we monitor the patients to look at their outcomes and the different things they undergo. And all these things could never happen without our EMU to allow us to do the video EEG monitoring, to allow us to do their different studies, whether it's an MRI or a PET scan, functional testing, cognitive testing, and our research program as well. So in conclusion, the EMU is a really specific and specialized unit for seizure monitoring, epilepsy evaluation. As you can see, it's got multiple moving parts with a very extensive team. We want you to be as involved as a family and ask those questions. And we're here to help you and help you with the diagnosis, whatever that may be, and give you the education you need. And then, of course, we just want to document everything that's going on with the seizure so that it helps us understand what those next steps can be for that patient. And it allows us to understand where the seizure is coming from and helps us guide treatment and therapy moving in the future for this family, for the patient and the family. And that's it. Thank you very much.